Next, I would like to introduce Dr. Flavia Petrini. She is president of the Italian College of Anesthesia in Abruzzo, which is in Italy, and she will talk about airway management for non-intensive care and non-anesthesiologists. Sorry.
Hi, my name is Flavia Petrini. I am a specialist in anesthesia and intensive care in Italy, working in a university hospital in a region of the middle of Italy named Abruzzo. Airway management is a cornerstone for anesthesia, intensive care, critical care medicine. But during the COVID era, everyone should know how to assess the risk, how to manage basically a patient with airway obstruction, how to assist him before expert arrives, how to organize a pathway for this patient, and we will discover if there are algorithms. First of all, the Difficult Airway Society algorithm, but something more for non-specialists. These are my disclaimer. I'm the CRT president in charge and member of the Airway Management Study Group, Italian Airway Management Study Group, and the European Airway Management Society. We have to reimagine the future in the COVID era for our hospital to be more flexible, more dynamic, and reviewing and improving clinical safety standards. We will choose the best procedure for clinical safety, but also for security. We have to organize this patient journey as well as possible with all the respect of wearing a mask, washing hands, social distances in the hospital too. Obviously, keep fighting with the problems, and when the patient becomes a critical one, we must organize the best response, and the airway team is a part of this response. Anesthesiologists working in hospital treating many infected patients have developed in this last month specialized teams and recommendation for the team responsible for airway management outside the operating room, because obviously the best room should be the OR, the theater, and the intensive care, but we have to organize also rapid response team for other levels of care and for the emergency department. Unfortunately, we know that a lot of people during this last epidemic were affected by COVID-19 during intubation, and everything must be done to avoid in the future this risk. The aerosol generating procedure, more risky for transmission, are all the invasive activities during intubation, but more and more during extubation or suction, or during diagnostic procedure like bronchoscopy to get a lavage. Awake intubation with the bronchoscope is a procedure adopted for difficult airway management, but should be avoided in this patient. And also simple procedure like face mask ventilation or CPR can be dangerous. So we are in the den of the best, and simple device could help to avoid the risk. This is the positioning of a double filter setting to prevent aerosolization during face mask ventilation. But what about during intubation? and how can we recommend to our specialist and to the other, to nurse, to organize intubation and airway management. These are two documents that I would suggest to you. One is the Italian document published in cooperation with the European Airway Management Society. The other one is the Difficult Airway Society Guidelines for Managing the Airway in Patients with COVID-19. They were published in the same period, and our groups cooperated one each other. As you can see, it was not the first step of our cooperation. In 2017, the recommendation for management of the tracheal intubation in critically adult patients were published by DAS, and we shared as experts some simple strategy to coordinate the team in the emergency department too. Otherwise, this was really a challenge, and we must change our paradigm in the hospital to avoid airborne contamination and to protect our colleagues and our patient. So some simple message. The first one is the acronym SAS, safe for staff and patient, accurate, avoiding unreliable, unfamiliar or repeated techniques, and swift, timely without a rush or delay. Because our patient in this pandemic have a lot of problems due to pneumonia, not always needing intubation, can be supported by non-invasive ventilation procedure, but during this procedure can be dangerous for the other patient and for our colleagues, for ourselves. So some simple suggestion. The first algorithm that we want to consider is the one recommended by the Society of Critical Care Medicine and by ESICM for the Surviving Sepsis campaign, in which on your left is recommended to minimize the staff in the room and to adopt and to consider the adoption of special devices like a video laryngoscope. In the middle of the algorithm, it is written to consider, obviously after a trial of non-invasive ventilation, monitoring the patient to avoid a delay in intubation. The recommendation of the Difficult Airway Society and the one of the Italian group are against a delay and underlying that intubation must be elective without any delay. Otherwise, it is not easy to transform an emergency intubation in an elective one. Every one of these patients should be considered at least an anticipated difficult airway, because we have problems due to limited access to the patient, limitation of time, limitation due to the personal protective equipment, unfamiliar environment. The patient conditions are not always well known, often are not known, and the emergency situation increases the risk of errors from the team. Otherwise, there is a psychological issue to be managed, and the team is really important. Every team should follow a checklist, and the Difficult Airway Society suggested a really interesting strategy in which we have a check of devices, equipment, drugs, organization of the team in the room, and the strategy in the middle to be followed in the plan A for the easy procedure, but also to choose plan B, C and D. In the right part of the checklist are recommended some monitoring and the step to be followed after the intubation. This is a really simple theoretical strategy that can help our team. In the same period, in March 2020, in Italy we had a big wave for patients in our intensive care units, and we published our strategy for airway management with the checklist, and the algorithm were included in the document. As you can see, these recommendations were asked by many countries, and we had to translate in different languages to share with our colleagues, and not only with UK speeches. The Italian checklist is very well underlying the team preparation, how to arrange the team to minimize the number of the members entering in the room of the patient. It's underlined that the most expert team members should perform the intubation and advanced airway control and ventilation inside the chamber, but is also underlined that it's really important that a second doctor is expected to be outside the chamber, available to help, but with personal protective equipment ready to enter, but outside to observe the situation. So the acronym is Stop COVID, to secure airway, team briefing before entering and before procedure, to organize a team pathway and competencies, to prepare the device, to check and to control the crisis, to check the cart and to control the crisis, to optimize hemodynamic and oxygenation, to vigilate and to control, to check the donning of the team, and to evaluate an integrated airway management if something invasive is needed, like the front of the neck access or fibroscope maneuver. Every time should be done a debriefing of the team, and obviously this is not so easy with so many patients, but these cases should be discussed with the expert to avoid errors in the next one. These simple mnemonic aids are useful because the prediction of the difficulty of the patient must consider that oxygenation is the first problem of these patients. So to predict the reserve of the single patient and to plan everything to prepare something to assist the patient. The position is really important of the patient and the position of the team during the oxygenation. We underline the importance of pre-oxygenation, but the risk of this maneuver, and the importance of the oxygenation during the maneuver, so procedural oxygenation, and following during extubation, avoiding the risk of aerosol of the virus. To predict the difficult airway in critically ill patient in intensive care is more problematic than in OR. We have obviously the role of severe hypoxemia and all the factors related to the patient, Malampati score, eventually a reduced mobility of the cervical spine or limited mouth opening, and even more if the patient is in coma or suffer for obstructive sleep apnea. One of the factors is the skills of the operator, and non-anesthesiologists are a factor of risk because the skills in this patient are really advanced. So this score, the Makocha score, has been adopted by the DAS recommendation, and there is a list of tricks and tips to avoid the problems, how to prepare the patient, how to position the head, and how to position the mask with a two-handed and a two-person to ventilate the patient, because we have to absolutely to avoid droplets in the room, and the skills in this case are really important, and to manage for devices recommended. In this picture you can see the minimal list of the recommended devices, and you can see that the video laryngoscope is one of them. As I told you, the position is important not only for the oxygenation by mask, but also for the to avoid hypotension of the patient. So complication of direct laryngoscopy can be difficult, and this could be predicted, but we have too many factors influencing the result. If we have to reduce time with a video laryngoscopy, we can do it, but also difficult video laryngoscopy can be difficult. For example, if you have an interincisor distance or a crowded mouth, you should consider the kind of your video laryngoscope, and it is probably now well implemented as a procedure, but you cannot learn in emergency. So you must try, because it's a completely different. But it is recommended because this can increase the distance between your mouth and your face and the mouth of the patient. So in this procedure, in this pandemic, video laryngoscopy has improved its importance for difficult airway management. A rapid sequence intubation approach is likely to be adopted using a cricoid force is controversial, obviously if there is the risk of regurgitation, and after in a pre-oxygenation, this can delay a little bit the rapid sequence intubation, but the pre-oxygenation is essential. Drugs must be prepared considering the risk of hypotension and cardiovascular instability of the patient. In this case, ketamine is recommended, but the most important thing is complete a full neuromuscular blockade before the attempt of laryngoscopy, because this will reduce the risk of cough. We have to minimize the apnea time, and applying the video laryngoscopy is the first choice. If the railroading of the tube fails, the reoxygenation should be or could be done with a second generation supraglottic airways that can be adopted to railroad the tube and for plan C. Sometime when difficult airway is certain or suspected, we can choose awake intubation that is indicated after topicalization of the airway and after a titrated sedation that can be done by expert people. In this choice, flexible endoscope is mandatory, and a separate screen is the system that can help the other people in the team to follow you and to help you. The rescue intubation through a supraglottic airway device, as told previously, is the plan C, a rescue technique that can help, following with the fibroscope the introduction of the tube. The plan D, obviously, in cannot ventilate, cannot intubate situation, will be an early cricothyrotomy technique. During the COVID-19 pandemic, single-use disposable flexible bronchoscope have had the potential to create a safer working environment in situations where the procedure, bronchoscopy for intubation or bronchoalveolar lavage, are unavoidable. The single-use procedure must be balanced in your hospital as cost effectiveness, and to consider the procurement decision of the single-use against the reusable bronchoscope depends on the number, on the experience, and on the cooperation of different units, as for intensive care and pneumology. Anyway, fiber optic intubation is only one of the indication, and the plan that includes it's obviously not the first one. So the algorithm of DAS on the left list the plan A for laryngoscopy, recommended video laryngoscope after pre-oxygenation and after protection of the team. The plan B and the plan C are rescue, oxygenation, and attempt to avoid the most dangerous situation, that is the cannot ventilate, cannot intubate situation, included in the list of the step on your right. The plan D, in fact, include the front of the neck access. It is not easy to choose this technique, and you must be prepared, and you must choose before the technique. In UK is recommended the scalpel cricothyrotomy. In Italy, for example, we recommend to our specialist to add skills considering Seldinger technique. The time is not so different, but the first choice is to avoid delay of this procedure, rescuing the patient. A previously published cognitive aids for the difficult unexpected airway is the Vortex Approach. It is pictured in this slide, but you must try to follow in three-dimensional way, because in the first step you must try intubation, preparing the size, the type, the suction, the oxygen, the muscular tone and the other drugs, and you must add in the plan B, C and D other procedures. Following the Vortex Approach, if you are unable to achieve the goal in the green zone, and if you are unable to reoxygenate the patient via a supraglottic airway device, the last chance that must not be delayed is the front of the neck access. And in this film you can see the monitoring, the importance of the monitoring, and the technique, the surgical technique, with the blood and everything else that appear. Adopting an introduction of the tube, railroading on an introducer can be one solution to minimize the time. Considering the risk of this procedure, laryngoscopy, intubation, cuff, and the front of the neck access, there have been different choices from different groups. One of these is the aerosol boxes, as to create a barrier and to enclose the head of the patient and your hand during this maneuver. We have seen how the box can protect during aerosolization. This was a simulation set, but just to underline that these devices are not yet validated by studies, and their use, even if experimental, doesn't exclude, obviously, any absolutely the protection given by PPE, personal protection. In the other film that I will show you, there is a set in simulation that is essential to coordinate the team, should be done before for the future, and we will see the different steps of the algorithm that we have seen until the front of the neck access.
In the following uncontrolled simulation, the participation of an assistant in difficult airway management is timed. Two identical simulations are carried out that progress from rapid sequence induction anesthesia to rapid oxyhemoglobin desaturation and a cannot intubate, cannot oxygenate situation that required an emergency invasive airway. Both intubation teams were aware of the plan, but the processes and procedures were chosen on their own. Whenever an assistant's hands are on the patient's airway or on patient airway equipment, the box around the overhead view turns red.
We cannot see the monitoring, but you can hear the sound of the lower and lower and lower oxygenation. They are preparing for the front of the next axis. Palpation to identify the cricothyroid membrane, the scalpel. The tube is railroaded over an introducer.
During the simulation without an aerosol box, the assistant had hands on the airway for 42 seconds.
You can see that there can be more difficulties within the
During
box.
the simulation with the aerosol box, the assistant had hands on the airway for 8 seconds.
It's essential after the intubation, obviously, to check the position of the tube with the capnographic curves that are mandatory inside the operatory room and intensive care, but furthermore during emergency intubation, after emergency intubation. And it's essential to avoid any circuit disconnections during ventilation following the intubation. And if needed, the circuit must be clamped, opening the connection with the endotracheal tube. Tracheal extubation in the critical patient is itself a risky procedure, as you have seen for the team, but also for the patient. So the management of the extubation is part of this continuum, not only in intensive care, but more and more in operatory room. Usually when the difficult intubation has been identified, the extubation must be protected with a specific device as this one. The extubation strategy could include some protection for the team, like the one showed in the film on your left. A facial mask can be adopted for the patient after positioning a nasal probe with oxygen, and after considering the possibility for the patient to breathe spontaneously, they are covering the mouth of the patient and are extubated the patient, covering for the cough. In this way, you can have somewhat protection for the team. On the other film, I will show a drape positioned over the patient like the boxes, but this is a drape that has been adopted in many institutions, at least in Italy, but in other countries too, to protect during intubation and during extubation. What about the tracheotomy or tracheostomy during the assistance in intensive care of the COVID-19 patient? We don't have algorithm or well accepted recommendation because everyone has to decide the timing and the place, the setting in which we can perform a tracheostomy for this patient, but we must be aware of the risk for during the procedure and after, during the assistance of the follow-up of the tracheostomized patient. So it is recommended that the ICU team or the surgical team adopt a decision plan deciding the optimal location in your hospital, deciding how to perform the technique, percutaneous or surgical, and trying to adopt a strategy balancing the benefit and the risk of the procedure for the patient, obviously, but for the teams in ICU, in the ward too. And key principles include simulation of the procedure, include the choice of the device, of the material, but also the choice to perform under a box or a transparent cover, as we have seen. Since we are not the only specialist involved during tracheostomy, it is interesting this publication, the recent publication, with different algorithms that can help you to choose in your hospital. This is an experience of the University Hospital in Italy of Bologna, shared with their anesthesiologist to perform, to follow, and to adopt the right protection for your nurses and your doctors in the ward when a tracheostomized patient come back. Considering altogether difficult management of the patient, of airway of a patient with COVID-19 needs a well-balanced decision-making plan that consider not only the risk, consider not only the recommendation previously published, but first of all consider the organization of a team that can be shared, because we will follow the patient in the ward. And we know very well that the most of the intubation are performed outside the ICU, so device must be available, and the early tracheal intubation of this patient must be taught. So we have to design a protocol to add the skill to our team. Nurses are really important, and all the staff, all the institution must be involved. The leader of this team, in our opinion, should be the anesthesiologist, as he is the more skilled in some maneuver, the advanced maneuver, but the team worker must know, all of them must know the strategy and the position of the devices available for the rapid response to the needs of the patient everywhere in the hospital, including the emergency department. In conclusion, airway management is not a simple procedure. It is not a matter of intubation or difficult ventilation, not only a matter. And in this prospective observational study, it is an Indian one, but it is representative of our convention, you can see the different degree of the level of confidence in various roles among the participants of the study that are not only anesthesiologists. So you have the airway assistant, the drug assistant, the laryngoscopy, during laryngoscopy and during supraglottic insertion, the different percentage of confidence. We are convinced that simulation, training in simulation is important after having built your personal hospital local-based algorithm, checklist and procedure in your hospital. Pre-debriefing, procedural debriefing and the discussion after the procedure are essential to improve your skills, but also to improve the decision making of your airway team for future practice. Considering the big number of the people involved in this pandemic, the only message that doesn't need evaluation in studies is that nobody saves himself alone, and so the teamwork between specialists and other is essential. Thank you for your attention.